Continue. All right, okay. So of course, you know there are multiple of endocrine glands involved in our endocrine system, okay? Because if you come to endocrine clinic, for instance, kan, you in one day to you be seeing multiple patients from different glands. I remember my first few endocrine clinic that I attend kan, sometimes you balik rumah tu you rasa macam which one I have to read on first, right? Because there are multiple of glands involved, and of course there are multiple of the feedback mechanism and everything that you have to read through. So the main thing that we're going to cover today is diabetes, because type 1 is the main diabetic in children. Of course, particular attention is given to type 1. But having said that, because type 2 diabetes is also increasing in prevalence, because of, why do you think type 2 diabetes is also increasing in prevalence? Anyone?
Obesity.
Right. Very true, because worldwide prevalence of obesity is also increasing, so that's why it's not so uncommon like before kan. Dulu macam if you have yang kurus is definitely type 1, yang gemuk tu is definitely type 2, but because the obesity in general tu is already increasing worldwide, so there might be type 1 diabetic patient who is also on the overweight or obese spectrum. So it's not as easy as before during this day and age. So that's why we need to make appropriate diagnosis, because the treatment is definitely different kan between type 1 and type 2. Okay, so we're talking about type 1 diabetes. Of course, the main complication that is very important to determine, to recognize, especially later lah, you'll be working as a houseman kan, usually you're the first liner in emergency department, for example, right? So that's why we would want our medical students and housemen to be able to recognize signs and symptoms of DKA, because if we don't think of DKA, you're not going to check sugar, definitely you're not going to be able to detect DKA. And then the third one that we're going to cover today is hypothyroidism, and mainly congenital hypothyroidism. Acquired can also happen, but of course, if you know about congenital in terms of the sign, the symptoms, what do we look for as such? Of course, when it occur in bigger children, that maybe is more of acquired rather than congenital in origin, so you would definitely will not be missing the diagnosis, I suppose. All right, okay. So we go to the first one, which is type 1. Yes, type 1 is the commonest, okay, type of diabetes in children. Although, despite people are more aware, all right, especially with among medical professionals, I mean, like, in Malaysia, but still, a lot of our type 1 diabetic patients still present with DKA. Okay, so the rate of, if you look at literature, the rate of DKA at the first onset, kan? I mean, like, when some children present with type 1 diabetes, the presentation may be just polyuria, polydipsia, right? But when they present with but when it is detected late, they can go on to have DKA. This ranges about 15 to 70%. If you're talking in between Europe and North America, that's the documented incidence lah of DKA. In Malaysia, in 2012, unfortunately, we don't have a much more recent data for Malaysia, because we do have our diabetes punya registry, but because of financial issue lah, funding and such. So that's why we are still not able to update our registry. So that's why we don't have a more recent data for diabetic in children in Malaysia. So in Malaysia in 2012, we reported that about 57% of newly diagnosed type 1 diabetes present with DKA. So I mean like more than 50% lah kita katakan, if 1 in 2 patient yang presented with newly onset type 1 diabetes, they present with DKA. Of course, we would like to have lower lah incidence of people yang present dengan DKA, because if DKA punya incidence is lower, meaning people are more aware of and catch or diagnose type 1 diabetes earlier. So if we look at the literature, the more prevalent ataupun the higher incidence of type 1 diabetes, especially Caucasian lah kan, Caucasian, Mak Saleh semua tu, they have higher incidence of type 1 diabetes. The rate of DKA is lower because people are more aware of the symptom. Because in Malaysia, sometimes you have, especially layman yang rasa kencing manis, takkanlah budak-budak dapat kencing manis, right? So that's why we still need to increase our awareness. So briefly, of course, we cannot run from talking about pathophysiology lah when we talk about diabetes kan, with the type 1 or type 2. So this is what of course what normal people who doesn't have diabetes respond. Of course, when you eat, your sugar go up, right? Once your sugar go up, your insulin will come up to help to control your blood sugar within the normal range. Okay, this is either will be stored in the liver and also used by the organs. But what happens in diabetes, especially if we're talking about type 1, type 1, there's no ataupun less. That's insulin deficiency or insulin insufficiency. So lesser insulin here. Your glucose, bila you makan, of course, sugar will go up, but you have less insulin to counteract that. So hence you have higher glucose, right? So in type 2, anyone? How does type 2 differ? Kan, we're talking about type 1, tapi type 2 macam mana? How does it differ in terms of the pathophysiology?
Insulin resistance.
Alright, yes. So the insulin is still there, right? You still have enough insulin, right? Yes. Or even sometimes they have higher insulin, kan? But the insulin at the tissue level, tissue does, is somehow resistant to insulin. Hence, although ada insulin, or sometimes they have higher production of insulin, where we call the state of hyperinsulinism lah, hyperinsulinemia, right? And then because of that, the end point is still increased level of glucose in the blood. So differentiating between type 1 and type 2 is very important. Hence, that's why lah we mentioned kan, the treatment would be different. Alright, okay. So symptoms and signs, of course, all of you already know what are the symptoms and signs of diabetes, be it type 1 or type 2. Like classical symptoms, memang kita kata all the polys lah, right? The polydipsia, polyuria, and then weight loss, and then when we're talking about aneurysms, usually it is secondary aneurysms lah. What is secondary aneurysms? What is secondary aneurysms? Anyone know? Macam mana? How can they present? Like what kind of history mom may give you when you're taking history lah? For example, you nak ambil history, macam mana? What would you ask the mother? Anyone?
Bedwetting.
Yes, bedwetting, right? Usually lah bedwetting, because that is also like a sign that you, especially in pediatric lah, you have to ask, especially because let's say if you're having a 10-year-old kan, no issue, memang dah toilet train for like the last 6 years, for example, but suddenly macam Mak mentioned that the last 2 weeks ni dia asyik kencing malam, doktor, right? But maybe if you don't ask the symptoms of bedwetting, which is what we call secondary enuresis lah, because before this dia memang tak ada dah bedwetting, right? If you don't ask, so maybe mother wouldn't wouldn't offer the information freely lah to you, right? So that's why it's very important to ask, okay? And then if let's say we go on to let the symptoms, if it's not detected early, right? Parents pun mungkin dah tak tahu pun that those are the symptoms of diabetes, right? So they won't present to GP, for example, right? So if it's detected late, then it will, they may present with vomiting, dehydration, abdominal pain, hyperventilation, drowsiness, coma, even death lah. So these are the symptoms of all this vomiting, semua ni, what are the
DKA.
Yes, so diabetic ketoacidosis, right? So be careful, because if you don't think of this could be a symptoms of DKA. I mean, let's say this is memang patient known diabetic, is fine, I have to think of DKA. But if it's a newly diagnosed patient, so if no one is thinking of DKA, vomiting, people may think that patient having AGE, for example, right? Abdominal pain, people may have mistaken. I'm talking not bukan hospital ulu-ulu dalam-dalam tu, even like big hospital pun have missed this. Abdominal pain, people may think macam gastritis, right? They bagi Gaviscon sikit ke apa, send home. And then rapid breathing. We have patient which has been given nap, salbutamol nap, bagi nap sekali dua macam tu, listen to the lung okay, tak ada rongkai, send home, right? So we do have cases that has been mistakenly diagnosed, okay? So that's why we don't want, because it's as easy as checking your blood sugar. If you check, then you will be able to catch the sign. All right, okay. So this is actually the 5 T's, 5 T that has been been one of the macam their campaign lah, their in order to increase the awareness in the UK. So thus the second T, toilet, because they're going to toilet more often to pass urine. They are so tired, lethargic, they are thinner. This is weight loss. And then what is the 5th T is what you have to do is to test, kan? So if let's say people are more aware of this, so they will hopefully catch early rather than late when they present quite bad with DKA. All right, okay. So I'm sure you have seen the diagnosis of diabetes. So this is how we diagnose diabetes in children. Is it similar to in adult? Do you know? Sama tak the diagnosis of diabetes in children and in adults? You have done medical, kan? Dah buat medical belum? Same?
Dah.
Right. So is it the same, do you think? Right. What do you think?
I think it's the same.
Yes, it is the same, right? So this is the same diagnosis is used for diagnosing diabetes in children as well as in adults, right? So you have that's why symptoms is very important. Okay, so you have this is random lah, I suppose, right? Random sugar. More than 11.1, more or similar to 11.1, fasting 7. This is OGTT if you happen to do OGTT on the patient, and then there's this is the latest actually criteria which has been added, which they added HbA1c as well, more than 6.5%. Okay, so any of this can diagnose diabetes, but with the exception, what is important here is the presence of the symptom. Okay, why do I say it is important? Because if the patient that is in front of you, you katalah dia tengah puasa and then you ambil dia punya sugar is 8. Okay, by definition, is, yes, it is already diagnostic criteria for diabetes. But when you ask history, mak tu or the child deny, tak ada, memang tak ada, minum banyak, kencing banyak, tak ada, saya tak selalu dahaga, tak ada symptom, tak ada weight loss, right? So if you have a patient who doesn't admit or who doesn't have symptoms of diabetes, one reading is not sufficient. You need to call back the patient later to have another, you check another random ke, petang tu ke, esok ke, you buat another random sample ke, to see whether, let's say yang ni dah fulfill, lepas tu the next reading you tengok yang ni pula pun dah fulfill. So then only you can say, okay, this patient has diabetes. Sebab dia tak ada classical symptoms. Okay, if the patient has classical symptom, one criteria is already enough to diagnose. Clear?
Yeah.
All right. Okay. So that's why it's very important. History is back to history. It's very important. All right. Okay. So kalau lah if let's say the patient dah memang sugar dah tinggi kat sini semua tu, tak perlulah you call back tomorrow untuk nak buat OGTT. Lagilah teruk kan you bagi OGTT. So if you have a few readings macam ni, there's no point to do OGTT. So not everyone that you need to do OGTT. Right. Okay. Okay, sorry, I know this is small, but this is available in ISPAD guideline. If you look here, ISPAD stands for International Society of Pediatric and Adolescent Diabetes. Okay, ISPAD. It is the guideline that we use. If you read your Malaysian PIDS protocol is written based on the ISPAD guideline. Available online, free je, you boleh download. Okay, so this, if you look here, sorry, this table showed the etiology of diabetes actually. Okay, so if you look here, the classification actually for diabetes, the first one, of course, type 1, okay, like we are discussing now. The second type is type 2, okay, the most common type, especially in adult. The third one is other specific type, because kan ada macam-macam lagi type of diabetes kan. For example here monogenic, yang genetic punya, and then yang because of disease of endocrine pancreas, for example pancreatitis, yang cystic fibrosis, for example, that can cause in our part of the world transfusion related iron overload. This is what when they're talking about transfusion related iron overload ni, what kind of patient usually have this?
Thalassemia.
Yes, especially common in this part of the world, right? Thalassemia. So there are, and the other one would be maybe drug related. Some drug may cause hyperglycemia, right? And then last but not least, if you have done your ONG punya posting, is your gestational diabetes mellitus. So this is how the diabetic has been classified. Okay, so but in our case, the most common is type 1. All right, okay. So yeah, this is what I have showed earlier, and then so those are the 4 main types. Okay, all right, okay. Right, okay, so when we talk about diabetes, we mentioned just now, right, because it is quite difficult to just differentiate by just looking at the patient. So of course we would like some of the clinical features that can help us, in making the diagnosis in terms of whether it is type 1 or type 2. Okay, so usually when we say type 1, usually younger age lah kan, but it can occur up to young adulthood for type 1 diabetes. All right, type 2 is quite uncommon to have like too young age, macam 5-6 tahun tu, of course usually is not so common. 7 years old maybe not so common. Usually what they say is around pre-pubertal age or later lah. Of course adult memang banyak lah type 2 diabetes. And how do they present? Okay, that can also help us in terms of differentiating. So whether they present acutely, rapidly, symptoms, usually 1 week or 2 weeks, right? So that is the typical presentation for type 1. But as compared to type 2, usually is very variable, and usually what they say insidious, because yelah macam kadang-kadang parents ke your grandparents for example kan, mungkin dah diabetic for the last 1 year or 2 kan, tapi dia hasn't been treated, hasn't been diagnosed for example, because duk pergi toilet, duk dahaga macam tu, like, but nobody check their sugar for example, right? So they can go years without having the diagnosis, right? But type 1 definitely no, it is more acute onset. Okay, autoimmune, yes, type 1 is autoimmune compared to type 2, it is not autoimmune. Ketosis, okay, ketosis, when we say ketosis too, whether there's ketonemia or ketonuria lah, whichever you detect the ketosis in, whether it's urine or blood, common in type 1. But nak kata ketosis never happen in type 2, no, it can happen in type 2 as well, but it is not as common as type 1. This is what we mentioned just now lah, body habitus usually much leaner in type 1, tapi because of the obesity like you mentioned, this increasing in frequency, of course it's a bit difficult now. Type 2 usually lah memang overweight and obese, okay, and this is also another important thing to look for. Acanthosis, right? Acanthosis nigricans. Where do we look for acanthosis nigricans?
At the neck.
Belakang leher.
Right,
Axilla.
neck,
In
leher.
cold areas.
Axilla.
Yeah.
Alright, okay. So axilla, right? Bilateral axilla, and then some even like the knuckles. Kalau macam it's quite bad, sometimes dekat knuckles is already thickened and darker, right? But that's another thing. I usually tell my patient that, you know, these are all, even like the obese patient that comes in, sometimes parents doesn't even know that this is signs of hyperinsulinism, right? Because usually parents will blame and say it this is like macam daki je, for instance, right? So this is not, so we have to educate our parents to be aware that this is one of the signs or early signs of diabetes, kan? Usually cakap macam tu barulah diorang rasa macam, oh okay, so this is back to awareness lah, I suppose. Alright, okay, so this is among the ways that you may be able to differentiate. Tapi is it enough? Usually sometimes it may not be enough, because sometimes it's quite difficult to differentiate even just by this criteria. So that's why we usually need more than just the clinical features itself, because usually what we will need is to send your other investigation, right? So we mentioned just now the autoimmunity, right? What are the insulin antibodies? Anyone know any insulin antibodies that is usually sent to check for a patient with diabetes? Insulin apa lagi? Antibody, sorry, insulin antibody apa? Any name that you can think of? Tahu tak? ICA, and then GAD, right? Anti-insulin, insulin autoantibodies, right? And then there's also the newer one, the fifth one is zinc, ZNT8. Okay, so nanti you balik, you baca lah some more of the types of antibody that we send. Usually in Malaysia we send to IMR lah. They do the insulin auto antibody for us. So usually we wait for the results. So in pediatrics, whether you think the patient is type 1 ke, whether you think the patient is type 2 ke, at diagnosis usually we still recommend to send insulin auto antibodies to see and help you make the diagnosis between the type 1 or type 2. Okay. Right, so the treatment, of course, it's insulin when we're talking about type 1 diabetes. Type 2 medication adalah kan oral medication, oral hypoglycemic agents. But for type 1, there's no other option but to start the patient on insulin. Okay, so this is the treatment or the regime of treatment that is available. So if usually we prefer, and a lot of study have shown that intensive insulin therapy is the best in controlling the glycemic control, because yelah, of course you want to make sure the glycemic control is good, because otherwise your complication will be will come earlier in your children. So intensive, the usual insulin regime is basal bolus regime. Okay, we'll talk about that later. And then number 2, there is also insulin pump. Okay, that is available, but unfortunately, because the cost is quite expensive, and mostly it is not covered. Insulin pump is not covered by the government, kan? So that's why it is many of our patients is not able to be on insulin pump. Although insulin pump is one of the best regime to be on lah, because it is it mimics your insulin physiological insulin delivery. Okay, less intensive treatment, of course we rather not have our patient on this. This is when they are on 3 injection or less, because yelah, lagi sikit injection, of course you cannot expect dia punya HbA1c to be good, right? Because the treatment is not intensive, right? So we try not to start our patient on the less intensive therapy. Okay, so this is what somehow what happens in our body, in everyone's body. Okay, so when you when you eat, okay, so if you see here, sorry, now maybe not too clear. Okay, if you see here, there's a light purple line. This is your basal insulin secretion. Okay, everyone, masa you tidur ke, masa you buat apa ke, everyone will have basal insulin secretion, because in our body memang akan ada sugar all the time. Even though you tak buat apa-apa pun, insulin is being secreted at over 24 hours. Okay, that is basal. And then what happen when you eat? You makan breakfast, and then you eat your lunch, and then you eat your dinner, right? So when you eat, like we saw earlier kan, during the pathophysiology punya slide tu, when you eat, the insulin will be secreted to cover the food, because if you don't have the insulin here, of course the patient will be hyperglycemic, right? And then when you makan lunch pula, your insulin will be secreted again, and then again dinner. Okay, then before, and then of course you have some time yang you would want to eat. Kat sini pula kan, pukul 10 punya tea time, and then pukul 4 petang punya tea time, for example. So if you eat here, maybe lah tak sebanyak ni, you eat some insulin, lower insulin will be secreted, and then if you eat small amount here, smaller amount insulin will be secreted, right? So that is what has been designed by Allah to maintain your sugar level. Okay, so your type 1 diabetic patient, of course, doesn't have this in their physiology. So what is the basal bolus regime is trying to do, is trying to mimic lah what happens in the normal body. So kita bagi the basal insulin, for example, glargine or detamir, right? There are a few types of basal insulin. So we give 1 dose or sometimes BD dosing to cover over 24 hours. And then this is the rapid acting or the short acting that we give to cover whenever patient wants to eat. Okay, so this is to mimic lah. So at least when we say the basal bolus tu, at least 1 injection here, 2 here, 3 and 4 injections of insulin per day. That is minimum. Okay, but remember when I mentioned to you, there's also here and here that people may choose to eat, right? So ideally, patients should be injecting here and here as well. Okay, so ideally at least 6 times lah, if you want a good control. Okay, but yelah, sometimes I know it's quite difficult, especially in small patients to get them to inject here kan. So sometimes what I would say, if let's say you eat very small amount, then only maybe you don't have to inject here. But if you're eating quite a big portion of food here and also here, ideally you should inject, because otherwise nanti sugar akan high lah kat sini, right? So that's why what we recommend our patient to do. So this is the basal bolus insulin to try and mimic what happens in normal physiology. All right, okay. So the types of insulin that we mentioned earlier just now, this one there's no ni lah kan, you have to read lah dia punya what are the different types tu, and then what is the onset of action, peak dia bila, duration bila, macam tu, right? So if you look here, the basal and long acting, so these are all the, yang bawah ni, these are all the basal insulin, okay, that we give usually once a day too. And then if you look here, this is the rapid acting, right? Or aspat, or more famous kita panggil apa, novorapid kan. So this is rapid acting, as the name is rapid acting, so the onset tu cepat, right? So within berapa minutes tu the onset is already there. So that's why with rapid acting or novorapid or aspat ni, usually we can tell patient whenever they want to eat, they can inject and terus makan. As compared to short acting, for example your Actrapid, right? The usual that is given. This usually, if you see, the onset is a bit much later compared to yang rapid acting tadi ni. So that's why for Actrapid, for example, yang short acting ni, they have to wait at least 20 to 30 minutes before they makan. So if let's say the food is there, dia cucuk dulu, and then wait for another 20 to 30 minutes, then only they can eat, because it takes time for the insulin to work. And so that's why sometimes it's quite difficult for our patient, especially yang younger child tu kan, makanan dah ada terhidang depan dia dah, you ask the patient to wait setengah jam kan. So that's why it's quite difficult lah, I suppose, right? Tapi because of the cost tu, maybe tak semua lah can have the aspat, the rapid acting. So some of our patients are still on the short acting. Okay, yang lain tu nanti you boleh baca lah. And pH, for example, your insulatard, semua tu lah. There are other options as well. Alright, okay. So those are the insulin injection or the MDI, right? Multiple daily injection. So we mentioned about the insulin pump right now, just now, right? So if you see here lah, memang this is the first among the first version lah, the insulin pump kan, macam mana besar tu. So it has evolved, and when it's evolved, it's very small, and you know, people might not know that you are wearing insulin pump because it is it is hidden under your clothes, for example, right? Do you know anyone maybe lah artis mana yang has type 1 diabetes? Do you know anyone? Siapa tahu? Hollywood ke, mana-mana ke? Anyone know?
Nick Jonas from the Jonas Brothers.
Yes, okay. Nick Jonas is type 1 diabetes. Anyone? Anyone else? Siapa lagi? Yang mana famous tu, tak kisahlah artis ke siapa ke. Siapa lagi yang ada diabetic? I think ada a few lagi. You have sportsman, right? Ada yang macam cyclist, and then there's ada racing car punya driver. Kalau dekat US tu NASCAR lah apa semua tu, there are a few of them are type 1 diabetic, and most of them are using pump lah. Even I remember there's this NASCAR punya racing punya racing driver tu. This is when, I don't know lah, he's famous kat US lah kan, bukan something like your Formula 1 tu lah, tapi dekat US tu NASCAR ni is very famous. So they even the driver, even they have a team of medical punya expert. Macam dia masa racing, dia bawa kereta tu, the team of medical expert tu memang tunggu dekat luar dia punya racing track tu memang they would know every every minute by minute tu they would see his sugar punya level, so they can control dia punya sugar punya level, and dia suruh dia makan ke minum air or something like that lah to control outside the racing punya track tu, because with all this development kan, and then if you know, tak tahulah mungkin bukan zaman itu, Halle Berry yang dulu berlakon X-Men tu jadi apa tu kan, Halle Berry yang that African American punya tu pun is also type 1 diabetes. Okay, so if let's say the control is good, glycemic control is very good, so there's no issue lah. Memang ada yang they live up to 70 plus 80 plus pun ada, because like complication, they don't have any complication, so that's why we want to aim our patient to have good control to minimize all this complication. Alright, okay. So yes, this is another picture lah. When we say the insulin pump tu, it's usually called the continuous subcutaneous insulin infusion, kan? So this is the insulin pump. So if you see here, dalam ni lah, this is where the insulin reservoir is. Okay, dah ada macam vial kat sini. So this is the insulin is secreted under your subcutaneous tissue. So dia bagi continuous delivery lah. So you can determine bolus berapa you can enter, you nak bagi 1 unit ke, nak bagi 2 units ke bila you makan, and you can also determine the determine the basal punya rate berapa you nak bagi 0.01 unit per hour daripada pukul 1 sampai 2. Sekali pukul 2 sampai pukul 5 ke, you nak bagi berapa rate. So you can control and adjust it accordingly. Okay. So when we're talking about diabetes, okay, so let's say lah you nanti if you have exams or later when you're working, right, you have a patient who is known type 1 diabetes. In the history, okay, when you're clocking, important to get the history of, number 1 is their self-monitoring blood glucose, or we call it SMBG. Okay, how obviously patient would have their book, kan, they have their diary with the sugar punya control, so you would want to see that. Okay, kalau lah patient tu tak bawa, unfortunately you have to ask them lah, okay, pagi what's the sugar like, between berapa to berapa, tengah hari between berapa to berapa, right? So roughly you want to know which time yang selalunya high, kan. Mungkin dia kata pagi okay je sugar saya between 4 to 7, tapi tengah hari pre-lunch then pre-dinner for example asyik 20 je, right? So that's why you want to know, because at least that can guide you to maybe make some of the insulin adjustment. And then of course you want to know how's the glycemic control, right? Other than the blood glucose punya level, the other thing is you want to know the HbA1c lah, because that tells you your sugar punya control over how long for the HbA1c.
3 months.
Alright, okay. So that's why when you working nanti, usually the lab tak bagilah you every month do order HbA1c in patient, dia akan reject je. Because usually it is done every 3 months. Okay, HbA1c. Kan, usually I would ask my student to ask the patient lah, ingat tak HbA1c yang paling latest berapa, because that also can tell you lah whether patient ni bagus ke tak, right? Dia know about the glycemic control ke tak, because that is very important. Okay, roughly berapa? 10%. So you know lah, not good, belas lagi lah, right? So usually you aim for 7% for example, right? Even in the UK, some of the guidelines say aim 6.5%, right? But yelah, our patient kalau kita dah aim 7 tu very good lah already, 7%. Okay, and then other part of the history is also important to know is diet lah. Macam mana, apa yang dia makan pagi, right? Apa yang dia makan tengah hari, apa yang dia makan lunch, dia makan tak before going to bed for example, ada tak supper, right? And then like we mentioned earlier, the tea break tu ada tak dia makan, pukul 10 dia makan ke tak, right? So at least kalau lunch macam tadi, the patient tadi tu, the lunch asyik 20 je, right? And then when you ask, masa pukul 10 masa kat sekolah tu asyik, memang tiap-tiap hari dia makan nasi lemak or makan nasi goreng for example, tapi dia tak cucuk. So of course you know, maybe that's the reason why the pre-lunch is always high, because there's a big portion of 10 a.m. punya food, but that is not accompanied by appropriate insulin punya injection. Okay. The next, of course, exercise. You want to know how's the activity level, right? Diabetic bukannya macam, oh dia ada diabetes, dia tak boleh buat apa-apa, dia kena duduk je, PJ tak boleh, apa semua tak boleh. No, it's not like that. We do have patient yang even though diabetic, I have patient yang masuk peringkat negeri punya archery lah, right? We do have patient yang squash peringkat negeri, for example, semua tu kan. But of course, we have to help them in trying to manage their sugar level, because yelah kalau banyak sangat activity, they're very active with strenuous activity, dia akan sedang nak dapat hypo. So maybe you have to get them to check their sugar more regularly. And then kalau rasa nak hypo tu, they may need extra calorie to make sure they don't hypo. As much as we want the sugar is good, tak tinggi, of course we don't want them to have hypoglycemia as well. Okay, and then you would ask about DKA, right? Berapa kali DKA? Kalau patient yang kata, oh ni dah kali ketiga dah DKA, kali keempat dah DKA. So of course you know that the glycemic control is not good. There's a lot of issue lah to need to be resolved in that patient. Okay, and then of course screening of complication, microvascular dengan macrovascular complications, similarly lah with your type 2, right? You want to screen for that and screen ask about their follow up lah. Kalau macam kencing ada ambil tak, and then mata ada check ke tak, right? So at least you know that they are having a proper follow up lah, proper care. And then last but not least, I suppose in terms of compliance to the compliance to the diet, compliance to the injection, right? So it's very important, because especially lah when they are getting older, yang kecil-kecil tu maybe it's easier because mom is doing everything, almost everything, right? But once they are a bit older, of course we give them more independence to do most things themselves, kan, inject sendiri for instance. So we do have a lot of compliance issue. Okay, even ada when I was working at one center dulu ni, macam they had one patient yang memang mom kata memang compliant, no issue, saya nampak dia inject dia, tapi one day mom was quite surprised, tengok sebenarnya memang dia inject, tapi masa duduk tu dia tak inject dekat peha dia, dia inject dekat sofa kat tepi yang dia duduk tu. So I mean, like, you know, there's a lot of things lah, because we're talking about chronic illness. Bukan sehari dua they have the, or 1 week or 1 month, this is lifelong. Okay, so that's why there's a lot of issue. Alright, okay. Okay, any question on type 1 diabetes before we go to DKA?
Doktor, berapa
Yes?
harga insulin pump?
Oh, okay. So insulin pump pun biasalah benda-benda macam ni kan, there's a range of the quality range of the device, to how much the device can do. Of course lah, lagi banyak dia boleh buat, lagi lah mahal. So it can be as expensive as 50k pun ada. And then the least expensive yang paling murah tu maybe about 8k pun dah ada, 8,000 pun dah ada lah, depending on, kadang-kadang dia buat offer sikit macam tu lah. So from 8,000 to 50,000 ringgit. Okay, so yang tu is the cost of the device itself. Tapi sometimes what we may overlook is yang tadi saya tunjuk you all the tubing semua tu kan. So dia punya device yang tu, lepas tu dia ada tubing, dia ada tape semua tu kan. That is what we call consumables lah, because dia macam pakai buang kan. Usually they have to change it every 3 days. Maknanya setiap 3 hari dia tukar yang barulah tubing semua tu. So that one pun sometimes can cost roughly about maybe 300-400 lagi, for mungkin kita cakap for 500 lah per month. So that they have to bayar for that juga. So that's why some of our patient might not be able to afford it lah. Tapi if you think about it, it's very easy in terms of, it's good because kalau dia nak makan sikit, dia inject lah, dia macam key in lah sikit. So lagi kalau macam dia nak makan lagi, dia key in lagi. So sometimes it's easier, especially with your toddlers yang kecil-kecil tu kan, because kalau tak banyak kali lah dia nak kena inject kan. But you might be surprised, some of our patient yang saya rasa can afford, tapi the parents cannot convince the child to use to take on insulin pump juga, because some people doesn't like to have something attached all the time kan dekat dia tu, sebab ialah tidur semua kena pakai, right? So some people might not find that to be feasible lah. Tapi we always give them option. Tapi with the pump tu pun kena, I mean like it's not good all the time. There's some risiko tu still ada, because if you imagine what the insulin that is given through the pump is the short acting. The usually is either novorapid yang aspat tadi tu lah, yang tu je, dia tak ada basal. So the basal tu is still novorapid or the aspat tu, but it is secreted in slow punya motion. So that mimics the basal macam tu. Sebab dia tak ada macam tadi kita kata yang pen tu dia ada macam glucagon, for bagi sekali dia ada 24 hours. So this pump ni tak ada yang glucagon, tak ada yang levomir, determine tu. So it is still given aspat is given in slow action to mimic the basal. So if you imagine kalau lah, if let's say there's issue with the pump punya failure, for example, pump for some reason pump tu tak boleh nak deliver, tapi macam patient tu somehow dia tak perasan pun pump dia ada problem ke apa ke, so they may go, yelah insulin tak masuk dalam badan, so they may go into DKA juga. So that's why you have to teach your parents to keep on monitoring the pump. And there are newer pumps ni yang kalau macam ada problem tu dia dah bunyi, ada alarm kan to tell you there's a problem, so at least parents boleh tahu, kata oh okay I have to check the pump or something like that lah. But in terms of glycemic control, patients usually have better glycemic control when they are on pump. Alright, okay. Alright, so if no other question for the time being, we go to DKA. Alright, okay. So DKA, we discussed about the presentation in the previous slide. Okay, what is DKA? It's diabetes ketoacidosis. Okay, so this you have to memorize lah. Tak ada cara lah. You have to memorize. Hyperglycemia, blood sugar berapa, the venous. If you have pH, usually venous blood kan less than 7.3, or bicarb less than 15, right? With evidence of ketonemia or ketonuria. So these are the biochemical criteria. The earlier one is the signs and symptoms that we look for. Okay, I mean like ISPEC, to make things easier, ISPEC kind of like help in terms of defining between mild, moderate and severe. So nak senang ingat, it's just yang tadi tu, yelah 15, 10 and 5, 7.3, 7.2, 7.1, easy. Okay, in terms of severity lah. Okay, so we discussed earlier about the pathophysiology of diabetic in general. Okay, now is what is the pathophysiology of DKA. Okay, so we know that there's deficiency in the insulin circulating in the blood. And then when there is also increased level of other counter-regulatory hormone. Remember, insulin is the only hormone in our body to reduce our sugar level, but we have multiple other what we call counter-regulatory hormones that can increase your blood sugar level. So insulin nak kena lawan dengan semua ni. So that's why in patient yang memang there's issue about insulin production, like our patient with diabetes type 1. So when they are unwell, for example, right, you have counter-regulatory hormones yang increase, so that may predispose them to have DKA. Okay, so when we say about insulin deficiency, when there's acute, absolute insulin deficiency can occur the newly diagnosed, we don't know, right? And then what about the patient that deliberately doesn't, non-compliance we mentioned just now, and also the one that I mentioned, insulin pump, tapi there's a delivery failure of the pump. Okay, that these all may cause absolute insulin deficiency. Okay, but there's also relative, okay, insulin deficiency, where when these other counter-regulatory hormones increase, for example, when the patient is stressed, sepsis, trauma, or GI issue, vomiting, diarrhea ke apa ke, so they may also cause relative insulin deficiency. Okay, so how do we manage? Okay, so because DKA is important, and then I know there's a big chapter in UITM. Usually we have one tutorial on DKA as well, but it's okay, don't worry if it's too much. You can always refer back lah later kan, read back at later time to go through. Okay, so but in general, what are we aiming for? In DKA, of course, you know, they will have hydration status is affected. They are dehydrated, so you want to correct that. You have acidosis, kan? You have ketosis, so you want to correct that. Blood sugar, of course, you want to make sure that it's come down, and then you monitor other complications and also any precipitating event. For example, if let's say the DKA is triggered by infection, patient is unwell, ada pneumonia, for example, like that, kan? Even though they are giving insulin quite good, but maybe patient not well, stress, and then with intercurrent infection, so they can predispose the patient to DKA. So you have to treat that event to make sure. Okay, so emergency, what do we do? Of course, we want to make sure lah sugar berapa, right? We want to make sure, sorry, this is your ketone lah, because what type of ketone do we have? Do you know? When we say about ketone, what type of ketone do we have? Yang ni apa? Yes, acetone. This is what do you think? Beta?
Beta hydroxybutyrate.
Right. Okay. So beta hydroxybutyrate. So this is usually measured in mana? Urine ke? Blood. This beta hydroxybutyrate.
Blood.
Yes. Okay. So this is your serum. Okay. And which is one of the best lah, because the urine punya ketone usually roughly it has delay in the clearance tu. For example, kalau kita ambil urine ketone, that might not be the real ketone at that point. So usually it is lacking 3 hours behind. So that's why we aim to have, ideally we would like to have serum ketone, tapi it's quite expensive. Get satu strip macam it's the same, it looks the same like your glucose punya strip tu. It can range from satu strip itself tu, it can be from 6 ringgit to 10 ringgit, or ada yang sampai 12 ringgit. So that's why it's quite expensive. And then the expiry date pun is very is quite fast, the expiry date. So that's why not many of our patients may be able to have that. Okay, so ideally lah, all ED ideally should have lah the serum ketone punya measurement. Okay, so you have to weigh the patient because you want to know later for the management, and also you want to assess the dehydration. Okay, of course you will do lah kan, you check for GCS, and then blood is also important kan. We mentioned that we want to determine whether patient need DKA or not. Of course from there you dah buat sugar, you would have done the ketone, you would also have done the acidosis. Okay, you check for the pH. Okay, and then these are all also other electrolytes is also important. Okay, full blood count, you want to make sure that whether the patient has infection, for example, like that. Okay, so these are all, when you taking blood, you hantar semua sekali. Alright, and then yelah, you want to secure the airway. Can the patient still be able to secure the airway, breathe normally? Okay, kalau patient tu dah almost unconscious, of course you need maybe NG tube, because kalau patient aspirated ke apa ke, problem pula. And then intravenous access important. ECG, because you want to detect whether the patient has hypo or hyperkalemia, or it looks fine right now, because remember that we have taken the blood for renal profile to check whether the potassium, how's the potassium like, but sometimes can the renal profile punya result can take some time to come back. So that's why ideally you have to connect them to ECG, at least to see the T wave, for example, lah, to see whether there's any abnormality there. And then, of course, if they're very ill, maybe you have to catheterize, can? Because you want to monitor the input and output for the patient. And not everyone should be started on antibiotics, but if let's say patient febrile, you think there might be some infection, I would start antibiotic. And of course, take culture before that. Okay, so this is from your PIDS protocol. Later you can, this is to summarize which is good from the presentation and all, and then later what do we do in summary. Okay, but to go through one by one, so we mentioned earlier, kan, the main thing is, of course, you want to correct the hydration, because you know they have been having polyuria. For example, the last 2 weeks, they haven't been eating. Lepas tu dia nak dapat DKA, duk muntah-muntah, having a lot of vomiting. So of course, you know, they'll be very dehydrated. Okay. So how do we help with this in patient with DKA? So the first thing is also fluid therapy. Okay, one of the famous soalan periksa juga selalunya, the treatment for DKA tu kan, they'll be like, okay, the first treatment you administer, dia akan ada insulin lah, apa semua. No, the first treatment you have to administer is always fluid. Fluid has to come before your insulin therapy, because just by giving fluid itself, your sugar is usually, it will come down trend. Okay, so you start fluid pun the sugar will come down already. Tapi maybe it won't normalize, tapi it will come down significantly. So that's why fluid is important. Okay, but insulin is important. After that, insulin will come, because lagi you tak start insulin, the acidosis will be there, the ketosis will be there, because insulin is important to stop ketone production. Okay, so yeah, usually DKA have a deficit, of course, and then usually lah, between moderate is roughly usually 5 to 7, and then severe usually between 7 to 10%. Alright, okay. So when we talk about fluid therapy, usually the latest guidelines say that we usually divide that into 3 categories. Whether the first, your patient is in shock. Number 2, whether your patient is not in shock, but they have severe volume depletion. Estimate of dehydration between 7 to 10%. And last is between mild to moderate. Of course, not in shock, it's just mild to moderate, and you think that is estimate between 5 to 7% dehydration. So you have to justify your patient ni letak dekat mana. The patient in front of you ni falls under which category. Then only it's easier for you to decide in terms of the fluid management. Okay, so if let's say they are in shock, like the first category tu, they need bolus, kan? Tak kisahlah any condition pun, you know lah, AGE ke apa ke, if they are in shock, dengue, if they're in shock, yes, they need bolus. Okay, for DKA, so bolus is still the same, it's 0.9% saline, it's 10-20 mils per kilo. It has to be given quickly as possible. You bagi fast lah, kan, rapid bolus, because patient in shock ni, kan? So that is the first one. Second one, dia tak in shock, but fluid ni very depleted. Okay, so yes, you still have to give bolus, 10 to 20 mils per kilo juga, normal saline. But you don't give like rapid bolus. You can give over 1 hour, or some you want to give over 2 hours. It's also okay. Okay. And then after that you reassess. Tapi if you feel that they are very much like volume masih very much depleted, you may give another bolus, for example. Tapi a lot of guidelines say, if let's say you're giving bolus, try not to exceed more than 30 mils per kilo. Okay, as much as you want to correct the hydration, tapi you tak nak overdo with the fluid itself, because that's not good for your brain. Okay, and then later after the bolus, you correct the hydration or the maintenance, you infuse over 48 hours. Okay, so that is the second. Then this is the ni lah, usually you tak bagi more than 1.5 to 2 times daily maintenance fluid kan, you tak nak overdo lah. The main thing, you don't want to overdo with the fluid. And then usually after initial tu, you may be able to reduce to half saline for example kan, tadi full saline, and then keep on assessing depending on the patient punya hydration, and then you have to look at the sodium, then osmolarity lah. That's why we do blood for example every 4 hours, 4 to 6 hours. Okay, right. Usually initially tu lah, we don't really push, we let the patient rest, and the patient is on IV fluids kan. Only later that if the patient is better, maybe lah after day 1 or after day 2 for example, we can slowly start oral intake. Okay, but not initial period. Okay, so the last one would be the one yang just mild to moderate volume depletion. This one of course doesn't need lah you punya bolus kan, because they are not too bad. And then you have to again lah, if let's say we mentioned just now between 5 to 7% dehydration, so that can be infused also over 48 hours. Okay, over 48 hours infusion of fluids too, because you still have to correct, although dia tak too bad, tapi they still have to have some fluid replacement of fluid correction on top of your maintenance fluid. Okay, so then don't forget the potassium is also important. Why do potassium is important to monitor in DKA punya management? Anyone know?
It can cause hyperkalemia.
What can cause hyperkalemia?
The insulin administration
Insulin.
causing intracellular shift.
Yes, so when you start insulin, the potassium can go to intracellular kan? So your potassium will be high or low?
Low.
Yes, so you have hypokalemia, right? So that's why you have to regularly check your potassium level. That's why lah kita tadi pasang ECG lah, apa nak tengok dia punya lead semua tu kan, because the treatment can also cause hypokalemia, alright? Because nanti you may run into trouble. Okay, so usually roughly you talking potassium in you have deficit between 3 to 6 millimole in patient with DKA. Okay, we mentioned about the intercellular punya shift ni, so that's why it's important. Replacement of potassium is important. Although the patient have normokalemia, okay, still they need potassium replacement, because once you start insulin, that potassium is going to come down. So that's why normokalemia, normal pun you still have to start potassium. Hypo lagi lah kan, you have to start higher potassium. Only for hyperkalemia at presentation, you may start, but you have to make sure that the urine output is documented, ada urine output, because you don't want to give potassium unless tiba-tiba the kidney patient has kidney failure kan, you bagi potassium lagilah potassium dia naik. So that's why you have to make sure that the patient has normal urine output before you give, kalau patient ada hyperkalemia. Normokalemia, hypokalemia, by all means you can start potassium. Okay, so now only we want to talk about insulin. Okay, so it's very important. Usually roughly insulin is started about 1 hour after you start fluid therapy. You start fluid, lepas tu 10 minutes later you start insulin. No, roughly plus minus 1 hour after fluid therapy. Okay, so this is what was that? That was just mentioning about the waiting about 1 to 2 hours lah before you start. Okay, so the dose that you have to remember for insulin is usually 0.1 unit per kilo per hour. But smaller child, especially if less than 5 years to, maybe you can start lower dose. Okay, but roughly bigger children we use 0.1 unit per kilo per hour, and usually it is Actrapid. Yang short acting tadi lah, that is the usual one that we start the patient with. Okay, This is when I mentioned that if they are very sensitive, younger children ke apa, maybe you have to decrease the dose of the insulin. Otherwise, we use that 0.1 unit per kilo. Okay. So yang ni I know it's a bit lengthy, but the idea is usually the rate of decrease in the blood glucose is between 2 to 5. Okay, and then when would you remember tadi we mentioned that it started 0.1 unit per kilo per hour. So when the sugar came down between 14 to 17, that is when you don't reduce the insulin punya infusion, but you add the sugar inside the fluid, because kalau you kurangkan dia punya insulin punya dose, the sugar might improve, but your ketones, your acidosis might not improve. So that's why although the sugar is coming down trend, tapi you still need the high insulin punya infusion to stop the ketone production and improve your acidosis. Okay, so that's why bukan terus kurangkan the insulin ataupun stop insulin. No, the patient still need insulin, but you add on glucose. Okay, right. Even here you can add daripada 5% glucose, maybe you can add to 10% or even add to 12.5%. Alright, okay. So if let's say lah tak ada improvement dengan DKA, you dah start fluids, you started insulin, tapi DKA dia tak improve, pH tinggi, ketone pun tinggi lagi, right? Sorry, pH is pun still acidotic, ketone is still high, right? So maybe you have to assess lah, is your insulin tu ada problem ke? Let's say your line bang ke, for example, right? Ataupun the dose not enough ke apa ke, right? So you have to reassess balik, because usually with proper treatment, patient will improve. Okay, so when the patient is much improved, the question is when can you start oral fluid, and also when can you change from the infusion, IV infusion of the insulin to the injection lah, your injection pen, your subcutaneous insulin injection. So usually, of course, when the patient is much better lah, appetite has come, kan? Daripada ada vomiting, the vomiting has stopped, right? The acidosis has improved, ketosis pun very minimal, right? So that's why that is when you see that, then only you say, okay, maybe I can start oral feeding and also convert the patient to subcutaneous injection. Okay, so alright. Okay, so we mentioned the other thing is bicarbonate. Okay, remember the patient with DKA have very low lah bicarbonate, kan? But I mean, like, of course we have a tendency nak start bicarb sebab dah low ni, acidosis pun quite bad, kan? But remember that bicarb may lead to paradoxical CNS punya acidosis, and rapid correction of acidosis with bicarb, if you give bicarb, may cause worsening hypokalemia. So that's why it is usually not recommended, but only in patient with life-threatening hyperkalemia, for example. So we don't give this in all patients with DKA. Usually in DKA with fluids and also with insulin, that should improve. Okay, all right. The complication, if we're talking, the most common complication in DKA would be CNS complication, and among the most common CNS complication is cerebral edema. Okay, but luckily the occurrence of overt cerebral edema is very low. Tapi even though it's very low, of course we try not to have our patient with cerebral edema lah, because you don't want the patient to have CNS complication pula dah ada DKA, right? So that's why we have to continue to monitor and make sure treatment is appropriate. Some studies have mentioned that approximately 15% of children with DKA has GCS score less than 14. So that's why we do frequent GCS monitoring, kan? Because we want to make sure that our patient doesn't go into cerebral edema, for example. Okay. Even one of the patient, I remember when I was in had not cerebral edema but have macam stroke like presentation. There's like hemorrhagic and also in ischemic infarct of the brain, but luckily patient survived. Initially had some aphasia because it's the area affected too, but now has much improved in terms of there's very minimal lah neurological punya sequelae, so that was lucky. Okay. Yes, so we said usually develop, kalau nak develop cerebral edema within the first 12 hours, but it can happen between 24 to 48 hours. Like in the patient I mentioned tu yang ada infarct apa semua tu, that occur after 48 hours. So that's why continuous monitoring up to 48 hours, even more is also very important. Okay, so this one you can read lah kan, what are the risk factor of cerebral edema. Of course, the younger lagi lah we worry kan, because they might not have any symptoms, they might not be able to tell you anything, right? These are among the risk factor which has been documented with cerebral edema. Warning signs, okay, headaches, right? Older children maybe can tell you they're having headaches, so you are aware, okay? Younger children, so maybe they won't be able to tell you. Okay, slowing of BP high, and then bradycardia, so that is another thing. Oxygen coming down, and other neurological punya signs lah. So that's why we watch for all these warning signs. Okay, so diagnosis, there are a few criteria. One diagnostic criteria, or if the patient doesn't have diagnostic criteria but have two major criteria, there's also a minor criteria. All right, okay, so don't worry about this, because sometimes I do have to refer in terms of making diagnosis to make sure that we are making the right diagnosis. So these are the diagnostic criteria yang ada kalau one pun dah significant, and then these are the major criteria, and also this is the minor criteria that I mentioned. So maybe we have to refer to the table to make the diagnosis, okay? But have high index of suspicion, I suppose, kan? To be more aware. Treatment is also, usually we prop up the patient, and then maybe we may have to reduce the food administration because you don't want to overload the patient, right? The most common treatment would be mannitol. Okay, don't worry about the doses and all. And the other treatment which is also indicated if there's no response to mannitol is hypertonic saline. So these are the two most used treatment for cerebral edema. Okay, so but we try hopefully not to have you to need to use this because we ideally want to prevent cerebral edema to begin with. All right. So this is also this is from your PICS protocol in view of your management. Okay, so what has been mentioned tu lah, mannitol and hypertonic saline. Okay, and you have also a summary of what do you look for. All right. Okay. Any question on DKA before we go to congenital hypothyroid? Sorry. Okay, so I know it's quite a lot because DKA is like usually one lecture, one tutorial by itself. Usually if we have seminar ke conferences ke apa, usually we have one separate topic of DKA. So that's why you perhaps you have to read on your own spare time lah to see what is the main things about DKA that we have covered lah. So go back and read. Okay. So last topic. Yes. Yes, Faisha?
I have a question.
Sure.
So the difference between the management of the shock and dehydration just now about the DKA. So the difference is in shock we give rapid bolus, right?
The one with shock we need rapid bolus. Yeah.
Is it within 1 hour or do we have a specific time frame?
there's no specific time frame, but rapid bolus, I mean like the one that usually 1 hour to 2 hours is those without shock, tapi you think that the patient has severe volume depletion. So that is also needs bolus, but the bolus is given between 1 hour to 2 hours. But those are with shock, the bolus is given less than 1 hour, and roughly usually between 15 to 30 minutes lah we give. I mean like a fast bolus lah, macam tu, between 15 to 30. It's not mentioned, tapi of course the faster you give the better lah, because patient in shock kan, of course you want to make sure that they are out of shock, BP normalize faster semua tu, that's why you're giving rapid bolus kan. But those yang without shock but they are very much severely volume depleted, you still give bolus, but the bolus can be given slower, between 1 to 2 hours. Okay?
All right, thank you, Doctor.
All right.
Doctor, I have a question. The common cause of DKA usually infections. So how long do we give the antibiotic treatments?
So I mean like you're right, infection can trigger DKA, be it a newly diagnosed DKA ke ataupun memang known type 1 diabetic patient ke, because the infection dia tak control dia punya sugar ke apa ke, so they go into DKA. Yes, it all depends on the type of infection that they have. For example, I suppose if they have pneumonia, so it is back to the treatment for pneumonia lah kan. I suppose your usual punya pneumonia punya treatment pun depend juga kan. I mean, I suppose the severe they are, maybe you give IV antibiotic for longer period. For example, let's say kalau they are much better, just sometimes we give over 48 hours je the IV antibiotic, and then once they are much better, we convert the IV antibiotic into oral antibiotic kan. And then maybe the cost is still the same, 1 week for example of antibiotic, but we tend to have depending on which patient and what kind of infection, we may depends on giving how many days on IV, maybe the other days we give oral antibiotic. So it all depends on what kind of infection that the patient have. Because some infection maybe kena sampai 2 weeks antibiotic kan, so it depends lah.
Yeah.
Alright. Kiazan.
Doctor, I have one question.
Yes?
Kalau parent tanya sampai bila anak saya kena guna insulin, kalau doktor jawab macam mana?
So it's very important, you're right, it's very important if let's say from the beginning, that's why counselling is very important once the newly diagnosed kan, because if you feel that the patient looks very typical of type 1, so I would from the beginning pun dah mention to parents, I suppose from the beginning lah, type 1 diabetes ni macam mana dia, sebab what is the layman punya explanation of how do they get type 1 diabetes. You have to explain that they are not able to produce insulin themselves. So because of that, memang they will require insulin lifelong. Unfortunately, you have to be very in a nice way kan, you put it in a nice way, but you have to be honest and saying that they really need that lifelong. They need insulin lifelong. Of course, they will ask, betul ke lifelong, tak boleh ke, is it, kenapa sampai seumur hidup kan, because this is a lot to take in kan. And then you would have patient yang ask, parents yang ask, tak boleh tukar ubat makan ke, right? So you have to explain that, okay, memang kalau yang macam diabetes yang jenis 2 tu, of course boleh ubat makan dulu, kalau tak okay baru kita tambah insulin, tapi ni diabetes jenis 1 memang tak ada ubat makan lagi yang boleh, so memang kena ada injection. So we have to be honest and from the beginning. And then usually kan counselling can be done over a period of few days kan, because there's a lot of to take in kan sebenarnya kan, dalam anak memang tak sihat, sometimes in ICU for example, and now you telling that they need insulin lifelong, tapi you have to be careful, you have to tell them directly, because I do have a few patients yang parents tried although dah educate, tapi parents try to off the insulin. Dia try ubat kampung for example. Lepas tu datang balik dengan DKA. Kejap sorry ada call. Hello? Hello? Yes? Daripada? Oh, okay. Alright, okay. Boleh. Okay. Oh, thank you. Alright, sorry. So I mean, like, they, of course, the parents wanted to try kan. So patient came back with DKA lah. So I said, luckily lah mother was being honest, kata sorry doktor, saya tak dengar cakap semua tu kan. So that's why I mean you have to tell them from the beginning. And then there's another thing about have you heard of honeymoon? In type 1 diabetes, sometimes they have a period whereby what we call honeymoon period. Pernah dengar tak? No. Okay. So what do we mean by honeymoon period? Because usually at the initial stage of the diagnosis too, maybe some patient after the period of DKA too, they may still have some insulin reserve, meaning the pancreas too may still have some residual function. So that's why maybe the first 6 months ataupun some patient may go up to 1 year, they still have some secretion of their own insulin dalam body. So maybe daripada awal tu you nampak you dah start a certain dose, maybe over time tu you see that the patient tu you boleh kurangkan dia punya dose of the insulin. So this is what we call honeymoon period. But after that honeymoon period to finish, you will see that the patient punya sugar is high and you nampak that you have to slowly increase back dia punya insulin requirement. Okay, so that's why I usually like to tell the parents about this period as well, because if you don't tell the parents, they may think kenapa insulin anak aku dia boleh cut down, aku try off lah sekejap sebab macam dah makin kurang ni, daripada initially you start 5 unit for example, masa breakfast, and then you nampak dia pakai 2 unit je for example, right? So that's why you have to tell them this is the nature of the type 1 insulin. They may go into transient punya honeymoon period tu, but it doesn't mean that the patient is going to to cure. Okay, so that's why the insulin is still needed, although the dose may need to be adjusted. So sebab ada a few yang macam nak try off masa tu sebab dose dia makin kurang. Okay. Alright, any other question on diabetes? Okay, so kita go on to hypothyroid lah, congenital hypothyroidism. Alright, okay. So incidence, okay, varies, okay, depending on where. So between 2,500 to 4,000, okay. In Malaysia, a few of the studies documented even 2,200 to 3,000 live birth, okay. Of course, you should know this better lah, because you have done your physiology and all. A lot of functions of thyroid hormone, growth, and then brain development, intellectual function, and also during the even as early as during prenatal and postnatal period, okay, and then also fetal punya lung maturation and also bone maturation, okay. So of course any when talking about any endocrine glands, any hormones, they are bound to have all the feedback mechanism. So for thyroid as well, is similar. From hypothalamus, TRH will be secreted, goes to your pituitary and is anterior pituitary. From anterior pituitary to TSH will be secreted, goes to your thyroid. Thyroid will release your thyroid hormone. So and then that's the negative feedback mechanism. Okay, so. And then when you talk about congenital hypothyroidism, there are a few causes, okay. Mostly about roughly 85% is from dysgenesis, okay. That could be from athyrosis or hypoplasia or ectopic, right. Ectopic can be dekat mana? What are the among the area that you have heard this thyroid may reside at? Kat mana lagi?
Lingual.
Where? Sorry?
Lingual.
Alright, yes, lingual thyroid. We call that lingual thyroid, or at the base of your tongue. Okay, because that is how the thyroid gland to descend daripada your pharyngeal pouches to, right, goes down and reside at your, in front of your neck, right? So kalau there's any problem during the descent, right, so that thyroid might not function normally lah, because normal thyroid function, normal thyroid gland should be able to descend nicely sampai kat tempat dia. Tapi if let's say there's some issue, some problem that may cause that the thyroid tu tak descend properly, hence the thyroid punya function pun maybe not sufficient to maintain the normal punya function. Okay, and then there are other causes as well. If it's not thyroid punya cause, maybe it's like pituitary or hypothalamic punya cause, right? And then there's other causes as well lah, whether this is the thyroid, there's resistance of thyroid hormone, and then some inborn error, for example, right? So there are other causes as well, but the most common is still thyroid in origin. Okay, sign and symptoms, of course you know lah, benda ni kan usually is common that we discuss about sign and symptom when we taking history or systemic review, semua pun you do ask about this, right? Infants mostly when they are born, usually they don't have symptom, not many have symptoms lah. And then later on, if you don't detect, because luckily now in Malaysia we do have TSH, called TSH screening kan, so we are able hopefully to detect. Tapi but for some reason it's get missed, for example it's not detected ke apa, and the patient is allowed to go on without treatment, they may continue to have some symptoms and signs of hypothyroidism. Okay, like listed down here lah. If left untreated some more, they might have overt clinical sign, for example the coarse facies, dry skin, microglosia, horse cry, umbilical hernia, semua itulah yang you've been reading in your textbook. Okay, so usually early at birth, maybe you might not have any sign at all. Okay, so that's why luckily in the 90s we do have called TSH punya screening program, which is good because we can detect earlier patient with hypothyroid. Okay, so you have seen lah kan this patient before and after treatment, right? So hopefully with the thyroid screening program in our country, we don't see this overt congenital hypothyroidism anymore. Okay, right, so this is just to reflect. Okay, so if you look at your TSH, and this is the days of life, so initially you do have TSH punya surge at initial period. So that's why if let's say during the cord blood too we detect high TSH, usually the patient will be recalled day 4, day 5, like that, to have their thyroid function test repeated, because you want to see whether the TSH2 has normalized or not, right? Because our screening program only involves TSH. We don't send pretty 4 kan masa early screening called TSH tu, so we just only send TSH. So that's why we have to recall to repeat the test. So remember about this early search of TSH. Alright, so this is in your PITS protocol lah. Of course, this is to tell you when usually we recall the patient, right? Call TSH if high. So usually after day 3 lah, day 4 onwards, like I mentioned just now too. So we know when to call. Okay, so this is to help you, because remember that most of our patient, if we don't do TSH ni, like most of our baby is discharged early kan, we don't have the luxury maybe in other countries like overseas punya countries yang European countries for example, like that, maybe the rate of delivery is not too much, the patient won't be discharged until day 3 for example, right? But for us usually babies are discharged earlier, so that's why at this moment we think cord TSH is the best screening method for our country. So that yelah, with screening method ni we want to do on most patient as possible kan. No point kalau you boleh buat on 50% je daripada delivery, so it won't be a good screening test. So based on the reading, so of course it has to be treated accordingly. So the classical congenital hypothyroid, you would have high TSH and low free T4. Okay. Then the treatment is indicated. Of course, the earlier you start the treatment, the better, because you don't want the patient to go on without treatment, and that can cause some complication. Okay. So how do we tell the parents to prepare? Of course, usually the thyroxine, the levothyroxine available in our country is in tablet form. So usually we advise our parents how to prepare, and it should not be mixed with soy formula. Kan, some of our babies are on soy milk, kan, because they, for some reason, they're not on breastfeeding. They're not, they cannot take formula cow's milk, for example. So they are on soya punya formula. So you would tell the parents that it should not be given together. Katalah baru makan ubat tu, tak bolehlah terus bagi soya punya milk tu. At least you kena tunggu lama sikit lah, a few hours before you give the soya punya formula, because otherwise it will affect the absorption of the thyroxine. Okay. And also not just the soy punya formula tu, any multivitamins ke apa ke yang contains iron, that should not be given together. So let's say kalau thyroxine tu usually lah we advise the parents to give in the morning, bangun-bangun pagi tu. Let's say if they are on iron punya supplement, it maybe has to be given at night time, for example, because you want to make sure the compliance is one. Tapi although parents is compliant, tapi for some reason you tengok-tengok dia mix dengan soy, or you mix with other iron formula, so that's why that is affecting the reabsorption. Okay, so that's why it's also important in terms of counseling the parents what not to do. Okay, the dose, okay, of course we're not expecting undergraduate level to know the doses of L-thyroxine. If you see here, I mean, like, just to summarize, the younger the age at presentation, usually you start with higher dose because you want to correct the free T4 fast, and then you want to make sure with that, you want to make sure the TSH also coming down trend lah. So that's why you start with a high dose. But later, you will notice that the requirement would reduce until roughly between 2 to 3 lah, roughly speaking. But you know, the patient to patient would be different. So you have to tailor it to your patient. Okay. So don't worry about the dose. You're not expected to memorize this. Okay. So how do we follow up? We have started the patient on the thyroxine. You follow up usually, obviously, just looking at this, the younger they are, of course, the follow-up is quicker, because this is when you just started the medication. You wanted to make sure that the TFT normalize faster, although remember that usually TSH may take longer to normalize compared to free T4. And then later when they are older, you can kind of spread out your your follow up lah, even 3 to 4 monthly, for example. And usually I would still see my patient 3 to 4 monthly lah kan. I mean, like, if they in adults ke, they dah finish growing, for example, maybe like you can do yearly, for example. But then during childhood, usually we still see every 4 months, for example. All right, okay. So when they are on treatment, okay, so some cases, you know, you may think that the patient might be only transient hypothyroidism. Maybe you may think that this is not lifelong, but initially you don't try to evaluate before 3 years of age, because at that point, from 0 to 3 years, usually thyroid is your brain growth is very dependent on thyroid. So that's why you don't want to stop your treatment here that can affect your brain development. Okay, so usually wait after 3 years before you think that, okay, I want to stop the thyroxine and see whether the thyroid function still normal or not, right? Because if your thyroid function is still normal, right, maybe the patient can continue to be off thyroxine, doesn't have to be on thyroxine lifelong. Okay, so there are some imaging that you may have to do, for example, thyroid scan, ultrasound, that may help you to see what is the etiology, the cause of the thyroid, the hypothyroid. For example, when you do ultrasound, they could not see any thyroid gland, for example, or they could see only one lobe, the other lobe is not seen, right? So maybe you could have some information to tell your mother, that, oh, okay, this might be the reason why the patient is having hypothyroidism and needing lifelong thyroxine. Okay, so I think that's my last slide actually. Okay, so back to having to know what is the physiology of the hormones, kan? If you remember the all the feedback mechanism, and then knowing what is normal, and of course knowing what the disorders can come with that. I know we just discussed about thyroid and then diabetes. Okay, I didn't really discuss about hyperthyroid because that is more of a postgraduate level. But of course, when you're taking history, you should know what is the symptoms and sign of hyperthyroid as well, because that would be the opposite of hypothyroid, right? But then hyperthyroidism per se is more of postgraduate level rather than undergrad. Okay, and the rest, growth disorder, pubertal disorder, and the other one is the congenital adrenal hyperplasia is also another thing. Please do read, although it's not common, but it does happen. Okay, any other question? Any question on hypothyroidism, for example?
Doctor, Assalamualaikum. I have a question.
Salam.
So if the baby has congenital hypothyroidism and she is breastfeeding, but in postpartum period the mother is on hematinics, iron supplement, right? So would that be a problem for the baby's medication?
Yeah, I mean, like the effect, how much is the effect, we're still not sure lah, I suppose, kan? But mostly, if let's say mom needs the hematinics, by all means she should continue, and she is breastfeeding. How much the iron crosses crosses into the breast milk too, I'm not sure, right? I'm not sure whether studies have looked into that. But having said that, breast milk is the best lah, I suppose, kan, for any babies, and of course we don't want to stop unnecessarily. So in that case, I would still advise the mother to continue breastfeeding, although the mother is taking hematinics, because usually if let's say it is secreted pun, not many yang usually any medication bukan, usually not many yang secreted in large amount in the breast milk kan. Usually I may maybe some exclusion or some medication yang kalau dia memang breastfeed memang tak boleh, kalau dia memang take that medication memang tak boleh breastfeed. I don't think iron is one of them, although it may affect, tapi maybe it's not maybe it's not too significant. So usually we tell mother to keep on breastfeeding, and then it's on you to I suppose check your TFT regularly lah kan, because usually pun if you see in newborn babies, once we started the medication, the thyroxine, we would repeat the TFT after 1 to 2 weeks kan. So we would have an idea whether we need to increase the dose or adjust the dose appropriately. So that should be okay. I think it wouldn't affect too much.
Thank you, doctor.
Welcome.
Dr. I have one
Yes.
question.
Mm-mm.
About the, you said previously that the most common causes of congenital hypothyroidism is genesis. So do we manage this genesis, or we just keep treat the patient by giving levothyroxine?
So usually with whatever the cause of the hypothyroidism, right, whether this is because there's dysgenesis of the thyroid gland, there's atopic thyroid, or the gland is memang there, no issue, normal anatomy, but for some reason the patient is still hypothyroid. So that could be dyshormonogenesis, right? Because the thyroid is okay, normal anatomy, but maybe the function of the thyroid hormone is not optimum. So that's why even though the anatomy normal, but the function is problematic. So whatever the cause of the hypothyroidism, the treatment would be still the same. In the patient, levothyroxine is the only treatment that is available, and it has been really well. And if you have to say among all the endocrine punya problem too, the easiest to manage is usually hypothyroidism, because it's oral medication and it's taken once a day je. And it's like macam taking multivitamin lah once a day kan. So it's among the easiest to control lah, I suppose. So that's why it's usually not giving much trouble lah, because sometimes the only thing maybe you have to keep on checking your TFT, and then maybe needing to adjust the dose, especially in children because they are growing kan. When they are growing, maybe the dose would need to be increased, but usually it's usually not much of an issue lah. And the treatment has still the same.
Doctor, I have one
Yes,
question
yes.
about the treatment.
Mm-mm.
Okay, so just now you said that we have to start the treatment as soon as possible for hypothyroidism. Do we start after we get the cord TSH test high? Because at first, physiologically it will be high and will decline after that. So should we when was the first of our treatment? When to start?
Yeah, good question. So yes, it should be started early if possible, once the diagnosis is made. But to really make the diagnosis, like you mentioned kan, the first is the screening punya test, which is our cord TSH. And usually we would repeat right the TFT just to make sure that you have a second reading lah. So if let's say the second reading too is also T4 is very low and then TSH is high, then yes, it is safe to start the patient on treatment. Because remember, if we commit, because usually the treatment kan once you start, tak adalah yang macam you stop after 1 week or 2 weeks after 1 month, right? So usually at least we continue until 3 years before we reassess again whether the patient can be stop the treatment or not. So that's why it's kind of like a long term punya treatment. So if let's say if you have any doubt that this patient you're not sure, the T4 pun macam not too bad, TSH is a bit high but T4 is still normal, for example. So maybe in those kind of cases you can wait for another 1 week and then repeat again TFT and see if the trend looks like going into hypothyroidism punya trend, then by all means you can start later. As much as yes, we want to start early, I mean like some literature say the first 2 weeks lah you want to start kan, not more than 2 weeks. But if let's say the thyroid function is not so convincing, that you can wait another 1 week to maybe repeat again and see, right? But of course lah, we monitoring of the patient lah. Kalau patient tu memang nampak clear cut, looks like hypothyroid for example, tu maybe you have to start earlier lah. But when we mention about that, usually initial period kan there's not much of signs kan or symptoms to look at. So maybe it's quite difficult just looking at the clinical features. So usually at the initial part tu, we rely on biochemical features lah. Okay.
All right, thank you, Doctor.
Welcome. Any other question before we end the session? You are all online now, right? Semua online
Yes, Doctor.
No face to face lah. BSC semua kan?
Ya, betul.
Alright, okay. Thank you so much. Okay, ada rezeki tu jumpa lagi. All the best. Exam you all bila? Tak tahu lagi
Tak tahu.
Bila, I mean like there's nothing certain now kan? Tak apalah, kita doa yang terbaik lah. Alright, okay. Thank you so much. Okay, all the best. Alright, okay. Assalamualaikum.
Thank you so much,
Doctor.
Doctor.
Thank you, Doctor.
Thank you, Doctor.
Alright, you're welcome.
Thank you, Doctor.
Welcome.
Thank you, Doctor.